Good morning, everyone. A little bit of a late start today. Thanks, everybody, for hanging in there. Dr. Conway apologizes for the train, but there's Amtrak for you. At any rate, Dr. Laskowski is going to introduce Dr. Conway in a second. I just wanted to welcome everyone to this Value Institute Symposium. We're really pleased to have Dr. Conway here. He's going to give us, I'm sure, a lot of insight into CMS and the Innovation Center. The format is his talk, followed by a discussion period that Dr. Laskowski is going to moderate, and that should take care of a good morning for us. So again, welcome, and Bob, for the introduction, please.
Thanks.
So we have
Tim, thank you, and thanks everybody for being here, and Dr. Conway, thank you for being here. A few introductory remarks. As I was thinking about Dr. Conway's visit with us today, I thought how appropriate to come and Value Institute Symposium from a whole number of perspectives. And in the brief introduction I'll give, you'll see those. But I ask you to think about a couple of things as the framework for this. The first is the Christianity way, and Pat, you have all around you see the Christianity way, and it runs, it's our mission and vision statement all put together, and our promise to the community. So we serve our neighbors as respectful, expert, caring partners in their health, and we do this by creating effective, innovative, affordable systems of care that our neighbors value. So in those words that we spent a lot of time putting together, you'll see that Dr. Conway's work is very directly relevant for us in our mission of service to take care of our neighbors. The second thing to reflect on and put his remarks into context and to think about the discussion that we're fortunate to have with him today is our strategy. And our strategy, of course, is value. And it's easy to say that. It is our work as health professionals to help define what that value is, but in ways which are not profession out, but rather experts to help our neighbors to understand things that are important to them, but most importantly, for us to listen to them. So that remember the Christianity Care way ends up with value here as being a verb. It's what our neighbors value, not just what we value. We play a role there in education and guiding our neighbors to help them to make wise decisions. But at the end of the day, it's their value that is what matters. And so the Value Institute, of course, and this symposium being one example of the way that we try to do this, is our effort to understand in an operational way what value means to us and most importantly to our neighbors. So with that, let me just say a few words about Dr. Patrick Conway. He's got many, many hats, and I don't know how you carry all of those hats around there, but if you think of something that happens in the Centers for Medicare and Medicaid Services, it pretty much maps back to Dr. Conway here. Among his titles, the overall title of Chief Medical Officer, but also a Deputy Administrator for Innovation and Quality, and in that array of responsibilities, he also leads the Center for Clinical Standards and Quality and heads up the Center for Medicare and Medicaid Innovation. So when you say lots of hats, that would be a lot of hats, and you see how that maps back to what we do and aspire to do in the sacred trust we have in serving our neighbors. So examples, clinical standards and quality, that's actually responsibility for all the quality measures at CMS, and the value-based purchasing, so hence the relevance to the Value Institute. We talk a lot about transformation, and that's one of the agendas of CMS is to help transform healthcare. And a vehicle for that has been the Center for Medicare and Medicaid Innovation, of which we've been fortunate to be an active participant in several programs. And this is really just magnificent. Compliments to you and the department for stimulating us all. Dr. Conway has a distinguished academic career as well, and has served at the Cincinnati Children's Hospital as a pediatrician, and his roots, I think very importantly for a person of his administrative responsibility, map directly back as a clinician. So it's a hospital physician and a pediatrician. Our paths indirectly crossed because Patrick is a graduate, I guess, of the Clinical Scholars Program at Penn that years ago helped to teach me a lot of stuff that has been very important in my career, and especially in terms of population health. Lots and lots of publications and lots of very critical thinking, and we're really delighted to have Dr. Conway here. So please join me in welcoming him.
Bob, thanks so much for the introduction, and Tim and the Value Institute for having me. I want to start actually by thanking you all. I know some about your work. I'm sure I'll learn more today, and it's been incredibly impressive. You know, your commitment to service, which you alluded to, your commitment to value and transformation of the health system, and really being a leading health system, demonstrating what's possible. So I want to start by thanking you for that. I've now been at CMS for about 3.5 years as Chief Medical Officer. The longest serving Chief Medical Officer of CMS ever is 5 years. So I'm getting close. I actually can see the light at the end of that tunnel now. I've been running the Innovation Center for about 1.5 years now, taking over for Rick Gilfillan. Today, I'm going to talk about some of our goals and early results, value-based purchasing, a bit about the Innovation Center, quality measurement to drive up improvement and future opportunities for collaboration. I will talk relatively quickly because I want to make sure we have time for discussion, but these are the highlights I'll hit on today. If you think about our historical state in terms of delivery system and payment transformation, we were often producer-centered, volume-driven, unsustainable, fragmented care, and based on fee-for-service payment systems. So we at CMS now are actively trying to work with the private and the public sector to get to an ideal future state. And I'll say, systems such as yours and many systems are far along the path to this ideal future state, to be people-centered, outcomes-driven, sustainable, and coordinated care for patients. And we're working on a number of new payment systems and policies to get there, everything from value-based purchasing to ACOs to shared savings to episode-based payments to advanced primary care medical homes, our transparency efforts in terms of quality and cost. So we're trying to pull a number of payment levers. I don't have a slide on this because it's sort of just new information. My new boss, Secretary Burwell, we were talking in the car, has very actively identified delivery system reform as one of her major priorities. Hence, I will have one call today that got told about last night. And she talks about it now in 3 buckets that I want to share with you. One is incentives, so getting the right incentives for delivery system transformation. 2, and I think this is critically important, tools and capacity for change. So I will tell you, I was one of the folks who pushed for that category, if you will. I really think we need to invest in supporting health systems, clinicians, communities, and improvement. And if we don't make that investment, you can have the right incentives and we won't get to where we need to be. So tools and capacity for change. And then the third category, information. So giving the right information. This is everything from transparency on quality and cost, but also the right information at the point of care, so that for that clinician and patient, you have the information you need about the potential clinical decisions, what are the quality and cost of those decisions. So really having that information at the point of care. This is a paper we wrote in JAMA a few months ago, talking about categories of payment for transformation. You don't have to memorize the details of the slide. Really, the main point is the 4 categories up top. One being category 1, fee-for-service with no link to quality. I actually just reviewed slides on the train on the way here, and I can tell you we have less than 10% of Medicare payments in Category 1. So almost all of our payments are tied to quality, at least in some way now. Category 2 being fee-for-service with a link to quality and efficiency, so the classic example being things like hospital value-based hospital value-based purchasing. Category 3 alternative payment models built on a fee-for-service architecture. So these are our accountable care organization models, our bundles pilots, our advanced primary care medical homes, and category 4 being population-based payment. And we have a few pioneer ACOs and a few payment programs with population-based payments. And these are payments to providers. So if you think about the current Medicare environment, you have 30% in Medicare Advantage and growing. But the question here is, how do those MA plans pay providers? We have self-reported data that about 15 to 20% of payment from MA plans is in alternative payment models, so category 3 and 4. I can tell you, because I just looked at the data this morning, we now have 17% of Medicare payments in category 3 and 4. So if you add up ACOs, bundles, primary care medical home models, et cetera, you have 17% and growing. If you think about MA and that 17% growing, MA is about 30%, 17% growing in the fee-for-service and alternative payment models. Very soon, we will have the majority of payments out of Medicare in alternative payment models. So you'll have a minority of payments in fee-for-service, and within those fee-for-service payments, as you all know well, we're increasingly linking to value, both in terms of quality and cost measures. I'll come back to this. It does mean we got to get the measures right, and we have work to do to get measures that matter in these programs, et cetera, and I'll come back to that. We wrote a paper with Karen Clancy, who's director of the Agency for Healthcare Research and Quality, about transformation at the front line. Most of my family members are small private practice docs across the Midwest. So we talked about, what's that look for that frontline clinician? How do we help drive transformation? We talked about quality measurement and having measures that matter, aligned payment incentives, so the right thing to do is also financially rewarded, comparative effectiveness and evidence available, health information technology, as a means but not an end, quality improvement collaboratives and learning networks. Then I won't talk much about this today, but training of clinicians in multidisciplinary teams. I do think this training in system redesign, quality improvement, et cetera, is often not part of the sort of basic training. I think it's increasing. I think we need to think about how we increase training on some of these components. I know you train people here, and actually I've heard you train people in innovative ways, so maybe we'll talk about that in the Q&A portion. I remember Don Berwick came to Cincinnati Children's when I was there, and we had a fellowship on sort of advanced system change. And in classic Don Berwick fashion, at the end he was like, this is terrific. This is an amazing fellowship. You know what? We need like 1,000 of these across the country. So how are you going to solve that problem? I don't think we've solved that problem yet in this country, actually, so the scale and spread of the training issue. I'm going to shift gears and talk a bit about some of the early results. So cost growth in this country, we've had the lowest cost growth in the last 5 years in over 50 years. Our own actuaries, who are relatively conservative, because that's how actuaries are, and their reports now say, a portion of this may have been the economy, and probably was the economy, but there's a portion that is fundamental delivery system transformation. So I think the good news on the cost side, and certainly more work to do, but we're making progress in terms of bending the cost curve. This is readmissions data. As you all know, 19 to 20% readmissions within 30 days in the Medicare population. This chart, actually, you can go back decades. I have this amazing control chart on my wall where it was rock stable, 19 to 20% for a very long time. We put in a combination of payment incentives and supporting quality improvement, systems like your own, doing interventions to decrease readmissions. We're nationally now, actually the most recent data is heading towards 17.5%. So that represents over 150,000 Medicare beneficiaries staying home and healthy instead of being readmitted to the hospital. I sometimes get asked, is it observation going up that's causing readmissions to go down? We actually wrote a paper about this. Observations going up slightly, but readmissions are dropping much more rapidly. So overall return to the hospital within 30 days is decreasing nationally. The other important, and I think not fully recognized fact and still a question of what's going on, overall hospital utilization per 1,000 Medicare beneficiaries is going down. So the population-based measure of going to the hospital going down. So then the question is, what are we doing with the communities we're working with to bring those numbers down? And I can tell you, we've looked at zip code and other analysis. It varies a lot by geography. So some real learnings on how can we learn where systems and communities have been successful, and likewise, how can we apply those learnings to maybe systems that have been more challenged. This is our safety data. The first bullet point is from the ARC National Scorecard. So this is 30,000 charts, so it's chart review data. Ultimately, I'd like to have the reliable, valid electronic measure of all-cause harm. We actually had that in our system in Cincinnati, but we don't have a national measure for that yet. So we chart reviewed to get this data. For the first time in history, from 2010 to 2012, patient safety in hospitals in this country improved at a national level. So actually a 9% reduction. I've seen the quarterly data for 2013. It's improving dramatically, so we're moving the needle even farther in 2013. That reduction represents 15,000 lives saved, over 500,000 injuries and adverse events avoided, and approximately $4 billion in cost savings. And I think another key learning here is, through Partnership for Patients out of the Innovation Center and our Quality Improvement Organization program, and you and your health systems, I think collectively as a nation, we had relatively clear measures. We could work on the measures being even more clear, and we have some claims-based measures that somebody may ask me about. But a more robust measurement system that still needs to improve. We invested in quality improvement, and I also think incentives had a role to play here as well. The bottom part of this chart is what we call the leading indicators from our Partnership for Patients hospitals. I'll just call out one as a pediatrician. Early elective delivery is a major risk factor for preterm birth and complications. In this country, we've decreased it by more than 50% over the last couple years. So I take care of children with multiple chronic conditions in the hospital on weekends. I can tell you almost every weekend I take care of a child who had a birth complication. So this, dramatic quality and cost impacts when we avoid those preterm complications. This is just the run chart from the network. The top line is hospitals in the network. There's about 3,500 hospitals in Partnership for Patients reporting data. So about 75% of hospitals in the network. And then the gray line is improving on 5 or more areas of harm, and that was defined as 30% reduction in 5 or more areas of harm. You've now got 2/3 of hospitals improving on 5 or more areas of harm by 30% or more, so significant improvements. The bottom line, I actually learned from one of my mentors, Uma Kodagal, that whenever you worked with a network, at some point just challenge everybody to reach best-in-class performance. So in the beginning of 2013, we defined the top 2% of performance for every area of harm, and then we just challenged all hospitals to meet that level. So this would be, for example, almost no line infections in a year. You now have 1/3 of hospitals achieving what we thought was best-in-class performance in 5 or more areas of harm. So this isn't, I'm not out doing this quality improvement on the front lines every day, so to be clear, I can't take credit for these results, but I think we built an ecosystem of improvement, and then frontline clinicians and quality improvement people in this system and systems like yours across the country are generating these results. And the most important thing here, I do like to tell stories some. The line infections, central line infections are down almost 50%. I still remember as a resident, the neonate we had pass away from a central line infection, and the attending at the time saying, these things happen, they're not preventable, which is actually what we thought. We now know they're preventable, and we're preventing them at a national scale. So I think for our country, really positive story. This is our Medicare Advantage star ratings. Main point of this slide, in 2009, 16% of Medicare beneficiaries were in 4- or 5-star plans. We now have 55% of Medicare beneficiaries. Real good example of, I did learn something in my clinical scholars days. We did a randomized intervention where all we did was we sent some beneficiaries a letter that said, by the way, you're in a 3-star or less plan, and here's the cost of your plan. Here are other plans in your geographic area that are 4 or 5 stars in their cost, some of which happen to be lower than the 3-star plan they were already in. The switch rate of that randomized intervention was unbelievably higher. We're working on publishing the results. So a very direct behavioral economic nudge that was successful, which now we're thinking about how do we scale that nationally. This makes health plans very nervous, especially if you're not a 4- or 5-star plan. But I would argue, we need to empower beneficiaries with information, and a good example of targeted information to beneficiaries. So I'll shift to value-based purchasing and quality improvement. We have a national quality strategy with 6 goals, things like making care safer, effective communication, working with communities, and making care affordable. We now have a CMS quality strategy that follows from this that we put online at the end of 2013. Our value-based purchasing programs, we're really trying to find the end goal, not the process for achieving it. You know, in the hospital program when I started, we had 80+ measures in the inpatient quality reporting program. We've gotten rid of, in the last 3 years, about 60 of those measures, added 15 to 20 that were more outcomes-based. Still more work to do, but we're removing topped-out process measures, replacing them with outcome measures, et cetera. All providers' incentives must be aligned. I had a meeting with the dialysis community recently, and now there's probably going to be a nephrologist who yells at me for saying this, but we're putting in a readmission measure in the dialysis program, and it is true that, you know, no one provider can control readmissions. As you know, it's a complex phenomenon, and there was pushback around, you know, we can't possibly control readmissions, and the reality is we are pushing to a shared accountability framework that, you know, even if you don't have complete control, we're going to measure what we think is important to patients, and then have that at least be part of a scoring mechanism for value. We're trying to have the right measures developed and implemented in rapid cycle. We're trying to actively support quality improvement and then get clinical community and patients actively engaged. This slide shows the amount of payment tied to quality and cost in our various programs. Congress, in their wisdom, has set up various programs separate in statutes over time. So now we have aligned those programs. So if you're a hospital, you can report once, receive credit for all programs. Likewise, physician would report once, receive credit for all programs. And then each program has a percent tied to quality and cost. I'll orient you to the middle box, which is performance year 2015. So in hospitals, if you add up hospital value-based purchasing, the IQR meaningful use program, the hospital acquired condition program, and the readmissions program, you have 8% for the performance year we're about to start, tied to quality and value. So as you all know, 8%, you know, significant, I think you'd say, amount of dollars tied to quality and value. And then on the physician side, if we finalize our proposals, we would have 9% tied to quality and cost. This does get to like getting the right measures, et cetera. There's evidence, as some of you may know, as you head towards double digit, it's really driving, it's more likely from other countries to drive significant provider behavior. So we're looking at 8 and 9% in the hospital and physician side tied to value. So I'm going to shift gears now and talk a bit about the Innovation Center. So the Innovation Center, for anyone who may not know, was established in the Affordable Care Act, $10 billion over 10 years to test new payment and service delivery models. And if they meet one of 3 criteria, we can scale them up to nationally and a duration that does not end. The lawyers have told me I'm not supposed to say forever, but we can put in rulemaking that there is no end. That's like classic government. You can't say forever, but there's no end date. And you're like, but isn't that the same as forever? You're like, no, legally it's slightly different. So, okay. So if they meet one of 3 criteria, 1, quality goes up, cost neutral. 2, costs go down, quality neutral. And then best case scenario, quality goes up and costs decreased. And I'll share, you know, we have a couple programs now with enough results that we're asking the question, do we scale them internally? And then actually, a little known fact, the Innovation Center, the funding auto-renews in 2019 if Congress does nothing. So this is another classic government story. My second day, I was like, what happens in 2019? My team looks at me and they're like, we don't know. We've been working so hard, we have no idea. And we looked into it, and actually somebody wrote a very smart clause in the statute that basically says if Congress doesn't do anything, you get another $10 billion in 2019. So, you know, that was a smart clause. Yeah, I know. I should be quiet about it. That's a good point. Sandy, you make a good point. I'm going to stop mentioning this in speeches. Yeah, keep it. And we're testing more than 20 major models now, and I'm going to talk some more about some of these in detail. But accountable care organizations, our primary care transformation models, of which there's a few, our bundled payment for care improvement initiative, some initiatives that we call capacity to spread, things like Partnership for Patients, which I talked about in Million Hearts, our Healthcare Innovation Awards, which I won't share a lot about today, but I will say I know about Christiana's award and really exciting work, and want to thank you for that and look forward to hearing more. I know we have some time, but we think basically we made investments in places like this one where we think we're going to learn what works in healthcare, both think about expanding the actual model and also apply those learnings across our program. So really exciting work. I'm going to talk about our state innovation models. I'm not going to talk about our dual eligible or Medicaid models today, but in the Q&A session, if people want me to, I can. So we've got innovation happening across the country, literally every state and territory. Accountable care organizations, as you know, promote coordinated care and population management. Over 350 ACOs serving over 5 million Medicare beneficiaries now. The year one results, over $380 million of savings. And then on the quality side, we looked at published benchmarks, and in the Pioneer ACO program, as an example, outperformed quality benchmarks in 15 out of 15 clinical quality measures and 4 out of 4 patient experience measures. The year two results we just released, I think last week, and wrote a JAMA paper about this. So Pioneer and Medicare Shared Savings ACO programs, total net savings of $372 million. Majority of ACOs in both programs actually generated savings. So some of those, and I know you all know this well, some actually outside the MSRs, they share in those savings, some within the MSR, but majority generated savings. And in the Pioneer ACO program as well, the vast majority, about 50% actually generated significant enough savings to share, 25% savings but within the MSR, and then 25% had losses. And then on the quality side, which was the most exciting, but no reporter wanted to write about, despite our best efforts, clinical quality improved 28 out of 33 quality measures in Pioneer, similar in Medicare Shared Savings, average performance from 70 to 84%. Patient experience improved in 6 out of 7 measures, and for any of you who've worked on improvement on patient experience, which I have, it's a hard measure to move. It's possible to move, but it's challenging because it's a complex phenomenon. And then, as I said, Medicare Shared Savings also improved quality and patient experience for almost all measures. So this program is actually successful. It's an interesting communications conundrum, too, because if you've watched the press at all, we had another Modern Healthcare article this morning. I'm like, who are these reporters and where are they coming from? But it was, 3 pioneers shifted tracks. So we actually designed the program so they could shift tracks, both MSSP and Pioneers. So it is not unexpected, and we actually did know this. The Pioneer results from, 600,000 plus beneficiaries in the model, and had high quality that improved, and has savings 2 years in a row. It starts to beg the question, does this meet the preponderance of evidence that it's successful and it can be scaled in rulemaking permanently? So I'm not decreeing that because we have to work with our actuaries, and I'm looking on Monday at the multivariable results to make sure it's similar to the actuarial results. But I think actually a good sign for our country. And I think we sometimes aren't communicating clearly to the lay public that transformation takes time. I mean, I can't tell you the number of reporters that have been like, well, 2% savings. I mean, and you're like, you know what? If we cut 2% off of all, the ACO growth rate is about 0.3% on cost. I mean, if our Medicare grew at that rate, we would all be in a much more financially sustainable future. So we probably have a collective challenge on how we communicate around some of these issues. State innovation models. So this was a model where we asked states, essentially we want you to achieve better care, better health outcomes at lower cost. We're going to give you a fair amount of leeway to do that. And we have 25 states in round one, 19 design states, and 6 test states. Actually, I should have checked. Delaware is a design state right now, I believe. Yes, sorry, I apologize. Thank you. And applied for tests. That's what I thought. So I can't comment on the application, but let me tell you a bit about round one and then talk about round two. In round one, you have states like Arkansas doing episode-based payments and primary care medical homes. You have Oregon doing coordinated care organizations. Not part of SIM, but Maryland actually came in separate from SIM and has a very interesting model where they're moving their hospitals, as many of you may know, to population-based payments. They've now signed up almost 100% of their hospitals to move to 80% or more population-based payments over the next number of years. So literally getting paid to keep people out of the hospital. So I've interacted a fair amount with Maryland and with the hospitals in Maryland, a very interesting model where it is, as one CEO said, I mean, he was like, the things I wanted to invest in before, now I completely am investing in community resources because I get paid more the more people I keep out of the hospital. So, complete shift of the sort of incentive structure. Probably scary if you're a hospital CEO in Maryland. I can tell you some of them are a little scared. But a commitment to the state and the hospital association that they sort of partnered to bring that forward. And we spent about a year working with them. And we are open to that kind of transformation for states that want to go there and have the stakeholders in the states engaged. After the hospital population-based payments, their plan, if it's successful, is to move all providers to population-based payments in Maryland. We have round two. We had, I think we've said this publicly, we have over 30 states apply to either be test states or design states. We have funding for up to 12 test states and up to 15 design states. Delaware did apply to be a test state, meaning to implement changes, so thank you for that. And we plan to announce hopefully in November if the reviews go well. Medicaid Innovation Accelerator, we also think, and give me a signal if I just need to be quiet and go to the other, this is the next part, but I'll try to talk quickly. Medicaid Innovation Accelerator, so we launched this over the summer. This really came from, in working with Medicaid programs, it's increasingly clear to me and others in CMS that we really needed to make an investment in helping Medicaid programs, everything from helping them design financial models to helping them on delivery system reform to data and analytics. There's actually a former RWJ clinical scholar, I don't know if she wants me to name her, but she's a Medicaid medical director somewhere. And she literally was like, Patrick, you don't understand. Like, it's me. I am the team. Like, I am my state's delivery system reform team. Now, I'm not saying that every state is that way. There's states that have more robust teams, but I think it was a sort of telling point for me that if we don't invest some resources to support Medicaid programs that really do want to transform, we may be losing an opportunity. So that's what this investment is. Bundled payments is exciting. So we are bundling typically 90-day episodes for various DRGs, acute care, acute and post-acute alone. Challenging program to implement, I will tell you. And we have quality measures on each of these. We have hundreds of participants that have already taken on two-sided risk, and we've seen a couple quarterly results which are positive. And we have thousands of participants debating whether to take on two-sided risk. And actually, I should know this too. I should have got, you're in the bundles program right now? I believe you are. Yes, oh, not yet, but will be. Perfect, okay. I think we have some internal work that I won't go into the details, maybe in a smaller group after if you want. We set up the program with our actuaries in a way that is highly likely to make CMS savings. I think our challenge is there's some volatility in the price estimates that for people that have moved into two-sided risk we're hearing about. So we are looking about volatility with small numbers, et cetera. And I've had those conversations with my CFO on quality initiatives. If you have too much volatility, it obviously concerns people because the concern is, you may have a quarter with significant losses. We've done some things like delayed reconciliation, meaning giving people some time before we collect, et cetera. But there may be more we need to do there. This gets into this is what I mean about this model. This one is really exciting, tons of people in. Thank you for your interest. I will say it is a model. Please do get in because I think I've adjusted this model almost once a month since I started 15 or a year and a half ago. It's a model that we're going to all learn together. We're going to have to make adjustments as we go. So that's bundles. Comprehensive primary care. This model, we partnered with private payers in 7 states and regions, and we said we want to pay primary care differently. So we're all putting in per member per month fees, all the payers, including Medicare and Medicaid. We picked 13 quality measures that are exactly the same for every payer. So a line set of quality measures. And then we put a shared savings opportunity on top if the practice is lowered cost. And we focus the practices on components of care coordination and transformation based on the evidence, things like stratifying populations based on risk and deploying interventions. I can't share the results yet because we just have the quarterly data, but the quarterly data on this is quite good in terms of cost and quality. So what are we focused on going forward? We are focusing on implementation of models. We're focusing on, and I didn't talk about this today, but I have lean fellows from other industries that I started deploying into CMS about 2.5 years ago, working on things like cycle time reduction. We reduced our contract modification cycle time by 90%. CMS writes a lot of contracts, so that actually really matters. So this is people never know this. So about 1,000 people at CMS work for me. In classic CMS fashion, it is a 1 to 25 ratio, so about 25,000 contractors. So it is like an exercise in how you manage contractors who don't actually work for you, but work for contracting organizations. So when I started, I actually talked to automobile CEO friend of mine about how they think about contractor management. And I know you guys think about this a lot in your delivery system, but some challenges in government contractor management that we're working through. We are focused on evaluation and scaling of results, integrating innovation across CMS, so it can't just be the Innovation Center. So all our models now are developed with our Medicare colleagues, with our Medicaid colleagues, really focused on, how do we integrate innovation across CMS and HHS. And then I will tell this story if it's okay. The portfolio analysis, my first job was at McKinsey Consulting. And so I was like, most of the people from that time are like in private equity and venture capital now, so I'll call some people. So I literally I won't tell all the calls, but they almost had the same one. But the one call, the guy was like, oh, I'm on my yacht. And I was like, oh, nice. I'm in my backyard. I'm like, so how would you think about this sort of $10 billion over 10 years? What they all said is to do as deep a dive as we could, data analysis on what we've invested in now, what is the likelihood of success, and then what are the gaps based on quality and cost in the various programs to guide future investment. So we did that, probably not as, with the resources we had to do. And this is what we came up with that we're working on these models now. The caveat here is I can never promise what model we'll announce because it goes through a clearance process that's bigger than me. But these are things we're working on. Outpatient specialty models, for example, oncology. So could you have a episode-based payment model for oncology, care management fees to redesign oncology care? So I think there's opportunities there. We're also looking at cardiac and orthopedic and other sort of outpatient procedures and what some opportunities might be. Practice transformation support. So we think that we probably need to make a fairly large investment in outpatient and physician clinician transformation. So how do you support those physicians and clinicians learning how to effectively measure quality, how to think about population health management, how to be successful in the current programs and be ready to enter alternative payment models and be successful. If you don't make this investment, we worry you're going to sort of leave a large cadre of clinicians behind. Actually, my sister on the way in today was like, if you guys don't help us soon, I'm selling my practice to the hospital down the street. And I'm like, okay, Kathy. Health plan innovation. We do think there's some things in health plan innovation, things like value-based insurance design, telehealth. Some health plans have come forward on palliative care benefits and that they'd like to manage people into the hospice program as opposed to the sort of way it's designed now. Actually, I didn't mention hospice models. We have a concurrent hospice model right now, although sorry, we have a model called Care Choices. I'm always the messaging. So Care Choices essentially allows beneficiaries to get palliative or hospice services at the same time as curative services. So we just took in applications. We got a ton of interest. We're going to be announcing the awardees soon. Having dealt with this as a clinician and for family members, as I'm sure many of you have, allowing beneficiaries to not have what is seemingly a false choice between hospice care or curative care, we think there's pretty strong evidence is highly likely to improve quality and lower costs. But we look forward to launching that model. We're looking at consumer incentives. We're looking at ACOs version 2.0. So this is how do you move to more population-based payments so you're not competing always against your own baseline. How do you bring in things like Part D and Medicaid potentially? So we're looking at what's the next generation of ACOs look like. And home health, we're also looking at some value-based purchasing and other models. So these are the last couple slides that I'll just fly through so we have time for discussion. Quality measures, as we said, need to reorient around outcome-based measures that span episodes of care. We wrote this paper about the opportunities and challenges of a lifelong health system. So if we accept the goal of a health system is to improve quality and health outcomes over longer time horizons and lower cost, and payers such as Medicare and Medicaid have insured people for longer periods of time now, what might we do differently? We talked about horizontally integrated health, education, and social services that promote health in all policies, places, and daily activities. We talked a bit about that sentence. If we executed on it, I'd say we'd have a higher performing health system. We talked a bit about consumer incentives and bundles. This community investment, especially because I know you all, from what I understand, do a lot of work here And we do think that there's a concept around accountable health communities that we need to consider. So how do you invest in communities in a way that really integrates the clinical care delivery system to the social determinants of health, to the supports, to the public health infrastructure, with the idea that then that community could improve quality and health outcomes and lower cost. A number of our state innovation models are doing this, where they're taking the funding and putting part of it into what they're calling accountable health communities. We've even debated, do we need to have a model on accountable health communities that allows communities that aren't in the SIM models to potentially test this. But I think, working as a clinician, taking care of many patients that are lower income with less social supports than we would want, it's how do we build a community infrastructure that really supports them when they move between settings and are out of the hospital. I know something that you all work on, so may know more than I. So with that, I just want to end where I started. I want to thank you for all of your work. I do apologize about being the train problems today, but really want to thank you for your work and listening, and look forward to the discussion. Thanks a lot.
We got the stagehands here setting up a nice discussion venue for you and Bob Laskowski, so please have a seat. We have plenty of handheld microphones that'll be available. Just raise your hand for questions. And obviously a very excellent, I would say a reassuring message from CMS leadership. This is a clinician, obviously a doctor, and I think lots of good challenging things for us to discuss. So Bob?
Thanks for your leadership, and it's really wonderful to see all the things that are going, and we are delighted to be participants in that. And as you'll see, my colleagues are not shy to ask questions, and we value your time as a discussion there. So lots and lots of things that are going on, and so I'm going to ask you, started off, the perspective that you have is a unique one. You're sitting atop of a lot of information and lots of things going on. In this era of reform that we embrace and applaud, what has surprised you most since the Affordable Care Act was started to be deployed?
That's a good question. So
usually I ask good questions, I don't have answers, but you do.
Yeah. I don't know if I'll share a few thoughts. So one, on the marketplace issues, which obviously had a lot of interest and focus, the interesting part there is it really is only one part of the Affordable Care Act, and the Secretary's talked about this recently. We really should focus on decreasing the uninsured, like how many people come in through the marketplace versus Medicaid, et cetera, not nearly as important as decreasing the uninsured rate. So the sort of focus on that, which I realize why that happened, obviously, but I think we hope we can pivot away from that, and I think that the level of focus on that became both surprising and unfortunate. I think the delivery system reform efforts, similarly, I think we're having a lot more success than I would have predicted, honestly, a couple, 2-3 years ago. So I think the transformation is happening more rapidly than I would have predicted. Granted, not everything's successful, there's variation still. It's surprising to me that we have failed to communicate that in a way that really resonates with the American people. And I'd say surprises and troubles me. So we've been doing some thinking, and the Secretary personally has been doing some thinking around, this really is a bipartisan issue. I mean, it's how you generate value for Americans. So, and higher quality care, time with your doctor, spend dollars more wisely. I mean, it should resonate, but somehow we haven't communicated it. So I think it's been surprising me on the delivery system reform efforts that we've been more successful than I would have predicted, and yet somehow have not communicated that clearly enough. I think the third area I'll just call out, the patient safety work, which is sort of a subset of number 2. When we started Partnership for Patients, it was classic Don, big, bold aims, everybody get on board campaign. It's been more successful than I would have predicted as well. So I'm glad, because it means Americans aren't getting harmed in hospitals. But as you all know, patient safety is a complex phenomenon. I think still work to do to, validate all the measurement. Peter Pronovost and I have had a back and forth on sort of measurement issues, validate all the measurement, ensure that, all the improvement is true improvement. But I think those safety results have been surprising and even better than I would have thought.
Well, thank you. Questions? Yes, Bill, and we have a mic, so let's, because we're...
Well, thank you for coming, and thank you for a wonderful talk. And thank you for the work at the Innovation Center. It's really been a tremendous amount to us here and helped drive our efforts forward. You'll hear a lot more about it over the course of the morning. One of the things that the Innovation Center that has done, and I think it's so important, is force kinds of research that are non-traditional. For those of us who've spent years in the NIH framework, non-traditional types of research, but it's necessary for the kinds of questions that you answer. So here's my question to you. If you're interested in doing such research and you want to go to the big federal pot at the NIH, and you want to look at a non-randomized approach to comparative effectiveness, well, good luck. The NIH is not attuned to such research, but it is necessary to drive our healthcare system forward. So I wonder what we can do overall in society to change the research agenda, and how we can get these key federal agencies to really work together and be on the same page.
Yeah, so a few thoughts. And at one point, I was executive director of the Federal Coordinating Council for Comparative Effectiveness Research. And when I was in academics, I did implementation research and comparative effectiveness research. So, so first, I will agree it has historically been a much more challenging area to get funding in. I would also agree, and I've written about this when I wasn't at CMS, that I think we have underinvested in a country in what I'll call T3 transformation, so the how of healthcare delivery. We talked about this, we interact with NIH on sort of where are investments that would be helpful, including at the sort of institute director level. On Patient-Centered Outcomes Research Institute, on PCORI, their funding is growing. I think increasingly will be an opportunity. AHRQ obviously has had a challenging funding budget over time. If they were to have a larger budget, I think this is the type of research they do. And then lastly, with CMMI, we have this interesting challenge. You don't want to duplicate what other federal agencies do, but we also do think we need to invest in sort of testing innovation. So, the Innovation Awards, we think were very strong investments. I recently had to go to the Hill, so and explain why they weren't duplicating ARC or NIH or PCORI. And I think we have I don't think they do. I think what I said was, we're testing new payment and service delivery models. That's a unique CMS role. That's why these aren't duplicative. Now, I do know that in your center, it probably helps the people doing the testing plus the researchers evaluating the setting, but that's fine, because we are testing new payment and service delivery models. So, and I think payers are getting more interested in it. Now, granted, it's, working with payers to fund research is not always successful, but I will say that private payers now are more thinking about, should they fund more payment and service delivery research.
Thank you very much for an excellent presentation. I have a couple. I'd like to just get your gestalt on a couple of things that are happening globally that have the potential to dramatically reduce the cost of healthcare. One of them is genomic medicine. I wanted to just get your gestalt on where you think we are with that. The second is detoxification, with what we're doing with our food and things of that nature, which is there's a lot of energy being put into that right now. And the third is, and you mentioned this briefly during your presentation, is telehealth.
Yep.
And where you think those three things. So genomic medicine, telehealth and detoxification.
Yep.
Just like to hear your gestalt on it, because it's a pleasure for you to have you here today for sure. And also, I'm sorry about your experience with the untrained train.
So on genomic medicine, I do think it's a huge opportunity. I didn't talk much today about the Center for Clinical Standards and Quality, but we do all the coverage decisions where we're trying to work with FDA, have a much more facile coverage process, figure out what we can cover locally with our local contractors and test innovation and what we need to do nationally. We had a parallel review pilot that was just successful. We've got some molecular diagnostic pilots that I think are exciting. So huge opportunity. We actually are working with NIH in this area as well, and FDA. Telehealth, I think likewise, we're doing a large number of waivers for telehealth in our various innovation center models. If they're successful, we could scale those models with the waivers. So telehealth, there's legal barriers that it would be up to Congress whether they want to resolve. We're able to waive some of those legal barriers in an innovation center model, and then if successful, either point that out to Congress and they can decide to change the law, or we could expand it using the telehealth, using the innovation center authority. So I think really exciting work, and I do worry that our payment and regulations are not keeping up with the level of innovation. Detoxification I don't know enough about to know for sure, but I think from the question it's sort of, I think another area of interest. On the researcher question, sorry to pivot, I also think health systems have to invest in some of this work. So I should have said that and I didn't. So at Cincinnati Children's, we certainly encourage people to be externally funded, but we also had chunks of people's time that we were paying for because it was critical to the mission. And I think we need more. From what I understand, this health system does that, but we need more health systems that do that.
We very much believe in that, hence the Value Institute. Yes,
Yeah. So we need more places like yours that are willing to make that investment.
I was, get to a colleague here in a second. I was heartened to hear about the hospice, being a geriatrician, and the integration of care. That seemed that the financing system was, as it too often does, was kind of wagging the dog here from the tail. One of the things that we have bumped into, which has been a bit frustrating for us, is a seemingly disconnect between home health care funding and the rest of the things that we're trying to do. And the home health industry, boy oh boy, been under a lot of financial pressure, and we're good people trying to do good work, but it's any comments on that? Because here it looks like if you want a low-cost place to do something, well, let's see, well, that'll be at home, okay, for most of the time. And as Lynn Jones tells me, we're a pretty full hospital here, and so we always have beds at home. There are always beds at home.
So this is oh man, where to start? I think you've identified a key issue. A few things that we've been sort of thinking about. One is, do we need to actually test some home health models very directly? So we are thinking about that. We are testing some things like independence at home and models that really focus on the complex and we think have real promise. One of the challenges with the home health industry internally, as you probably know, is you've got a component of really high value, high quality producing part of the industry, and then you've got a part of the industry we worry about. To give you a tangible example, each year we've done quality reporting, 5 to 8% of home health agencies refuse to send us patient experience data, even though they take a 2% hit. So every year we pass those off to our program integrity colleagues to say, either there's only a few possibilities. They don't have patients, worst possibility. They have patients and the care is so bad they don't want to give a patient experience survey. Or, category 3, maybe they just didn't really understand the rules, although some of them now are multiple years. So you got to wonder. So I think we have to innovate and also, and this is true of a lot of our programs because they're volunteer programs, innovate, but also do it in a way that we have sufficient protections for the beneficiaries. So people that truly want to innovate and add value are able to, and we limit the risk of people who are actually not trying to help patients doing actions that are problematic.
Yeah, yes, sir. Thank you.
Hi, I'm Lindsay Slater, a nephrologist. I appreciated your first comment there. I wanted to ask, how do you envision this system? Because I think is it going to encourage cherry picking of patients? So how are we going to encourage people, getting care that are in the less desirable populations? I've had a lot of experience, obviously, with the bundling system, and I think that has worked very well. So I'm glad to see that that's part of the initiative. And the other question I had was, how do you deal with the non-compliant patient? Because as you know, nephrologists get a lot of that, and we continue to struggle with that issue.
Yeah, so a few thoughts on the sort of cherry picking issue. We worry a lot about unintended consequences. We try to deal with it a number of ways. So one is literally just monitoring, et cetera, and identifying issues. Two is we do try to, when allowed within the law, we try to reward improvement. So at least if you're able to improve with a population over time, we give you credit for that. So hospital value-based purchasing allows us to do that. The ESRD quality incentive program allows us to do that. Granted, I know on the QIP we still are working to get the right set of measures and risk adjustments. Actually, 3 is risk adjustment, trying to make sure that we are adequately risk adjusting for the things we know. So I think those are a few thoughts on that, and happy to talk more. There's sort of an array of policy levers we look at to try to minimize that risk. Oh, and rewarding, so like physician value modifier, basically if you are in the top quartile of complex patients, if you do well with that quartile, you get added bonus points. So it's actually directly rewarding people who take care of very complex patients. And then, adherence, and then I sort of glossed over this, but what we were calling consumer engagement and incentives is actually, do we need some additional models around direct patient engagement, direct adherence? So we've got a number of innovation awards showing whether you call it adherence or compliance or engagement. I won't go into the semantics unless you want me to, but that show dramatic increases in sort of medication adherence, et cetera, through some interesting technologies such as lotteries and consumer incentives. Some of them are actually out of Penn. So we think that's an interesting area of behavioral economic work that we need to think about investing more in.
Ginger, Dr. Collier.
I had 2 questions, one of which with respect to patient engagement you answered. I think that's a very important component. My second question is, I was in Washington, D.C. about 3 to 4 years ago at your innovation conference, which was basically kicking off a lot of your activities. It was one of the most energizing days that I've ever had. What I saw was not just public CMS-type information, but there were a lot of private companies presenting too.
Yep.
So I wanted to know what your current activities are centered around public-private partnerships.
Yeah, so I think this area is critical. I'll name a few. I mean, I had it on one of the slides as sort of that one slide with the public and private and the historical and current. I mean, that's sort of how I think about it, and that you really do need both. So let me name a number, and then we're actually going to do another one soon with the Innovation Award. So we do conferences that are literally, let's share the information. 2, we have all sorts of private firms that are part of our Innovation Center models, and we think that's terrific. So everything from, I'm going to help an ACO improve with this technology to I'm going to be the best population management stratification tool known to man, and we'll connect. We can't endorse because we're the government, but we'll say we're going to have a learning session with all the ACOs. We're going to have 5 private sector entities talk to you about their tools. It's up to you. We're a connector. We can't be an endorser, but we can be a connector, and we're trying to do that actively. Private plans, just to mention this, when I became chief medical officer, I basically was like, so we meet with the private plan CMOs, right? And the answer was no, we never do that. We actually are allowed to. There's things we can't talk about, but I meet with all the private plan major chief medical officers regularly, so about every couple months, and we talk about, what can we learn from each other, what are various entities, so it is direct, what are the measures we could align on. So I mean, we don't break any of the rules of what we can't talk about, i.e. like exact contracts, et cetera, but it's driven a lot of public-private sector alignment with health plans. I think there's more work to do, but that relationship is critical.
Sure. So again,
You
please.
mentioned that Medicare admissions are going down in hospitals, which
Yeah.
fascinates me. And are we doing a better job of keeping Medicare patients out of the hospital? And you also mentioned
Yes.
that you could geo-sort it. So where do we see it happening the most aggressively?
Yes, so great question. The short answer is yes, we are, as a nation, doing a better job of keeping Medicare beneficiaries out of the hospital. So it's in the paper. I will try. The percentage was around 7 to 8% reduction over a 2-year span of admissions per 1,000 Medicare beneficiaries. It is variable by geography. A few markers, and we could use some researcher to help us with this if somebody wants to volunteer. But a few markers. So where we have CCTP, community-based programs, and others, those communities often are doing slightly better. QIO for places where the Quality Improvement Organization is investing in communities. Where we have a leading health system that is invested in the community, those communities are often doing better. Some of the worst performing communities, which we should all worry about, which gets to the sort of unintended consequences. One of them is in the Baltimore area. It's a low socioeconomic community. When we identified that, we actually put dollars, Quality Improvement Organization, significant dollars into that exact community. Because we basically said, you've got a rate that is dramatically different than the rest of Maryland, and is driven by probably SES factors. And so what are the resources we need to put into that community? We actually did private sector engagement too. So the city of Baltimore brought in some private partners to think about so we targeted the 200 lowest performing communities in this country and directly tried to invest in supporting them.
Eric?
Well, one of the things I wanted to mention is that within the Value Institute, we are actively trying to align our research-based activities with the 6 domains of quality that your organization has outlined. Care coordination, population health, et cetera. So we're well along
I
our
do
way.
this for a reason.
Right. And we're going to show you that later today. So we're really excited to show that with you. The one question I have deals with the social determinants of health that you mentioned near the end of your talk. When you think about the determinants of health, about 10% of those determinants are actually aligned with health care, where the majority of them are actually outside the health care system. I'm trying to figure out how does one align, like health care exchanges, all of that, to drive those needs outside the health care system. What are your suggestions?
A few thoughts. And I'll do so on the core payment programs, we are soon going to start giving people feedback on community measures of performance. So if you're a hospital or a physician, I wanted this to go faster, it's taken a while. We do have measures of community performance. So I think at a minimum, we need to start giving hospitals and physicians that feedback. Here's your admission rate for your community, other metrics of, some community level performance metrics. Ultimately, you could imagine a small part of payment being tied to community. This sometimes gets people very nervous. But the question, the pro-con, the pro would be, you're part of your community. You may be able to shift community performance. The con is, can I really control my community? There's a lot of social factors that are very far afield from my delivery system. I also think there's some payment and service delivery models we could test here. So I do think we have some communities that have basically built entities that are funded by various providers and payers and others in the communities. Rochester is an example. And they provide services. I mean, it's a community-based entity that is providing services that becomes financially sustainable. What places like that have told us is you need to put out a model. They've told us to call it accountable health communities that challenges other communities to get there. And if you put in a small amount of catalytic investment, this will spread. I think that's an interesting concept, and we're actively thinking about it. We haven't, I will share a patient story if that's okay. Because we haven't, I work in the District of Columbia. We have not solved this in the District of Columbia. I recently had a 15-year-old with a 34-week, former 34-week, now 2 weeks old, had driven from Florida to D.C., didn't have WIC in D.C., was given a boost-like substance, don't ask, infant was given that, had a seizure, came into the hospital because of very high blood sugar. Luckily did better next day, blood sugar normal. The resident literally was like, oh, everything's good. I'm clicking discharge on my EMR because glucose is fine, not seizing. just generated an educational opportunity. So when we go to talk to the family, doesn't know where she's staying that night, doesn't have WIC, doesn't have a primary care physician. Actually, in the DC area, nothing against DC, but not like many areas of the country, challenging to find on a weekend, because guess what? People get sick on the weekend. The right social services. So it took a fair amount of work from the team to get her set up with WIC, with formula, with a place to stay, with a primary care doctor visit the next day, et cetera. And it shouldn't be that hard, right? Our strategy can't be, hard work on a weekend by the clinical team. And we still need to do that, but the longer term strategy should be much easier to connect to the resources that patient needs, even on a weekend.
Roger? Yeah.
How nervous are you that with a change in administration or Congress, or whatever it might be, that a lot of the good work you're doing might flip? Or is it your sense that below the level of Congress, most of the people in DC are sort of buying into the change and looking for the new payment models and these sorts of things?
Yeah, so I think we have a lot of momentum, and if we keep that momentum for the next couple of years, it'll keep going. I should have said this. I'm actually not a political appointee. So I've worked in Republican administration at one point as a White House fellow, and then in the department as chief medical officer, what's called ASPE, sort of the think tank for the secretary. And when I came back this time, I'm the only center director at CMS who's not a political appointee. And so, I have the potential to be here a long time. My limiting factor literally is, and Sandy knows this, we've talked about it, I know why people haven't lasted. So the median is 2 years for my job. It is the most challenging, hellacious, horrible job on some level I've ever had in my life. I also think it may end up being the most rewarding job I ever have in my life, which is kind of scary. I hope anyway, that's a longer philosophical discussion. But, it is, so I think we've got momentum. I think if you scale some of these programs the next 2 years, you don't have, you avoid major unintended negative consequences, which I think we can. I truly think this is a bipartisan issue. I'll tell you on the Hill, I've been meeting with the staff every month, bipartisan, or almost every month, and we've shifted the conversation to it's closer to how do we do this, as opposed to why are we doing this? What am I going to bring you up on oversight? And I think that's good. That's good for our country.
So we have time for a couple more questions.
Okay.
Bettina and then Vernon, and then we'll close out. Or go ahead, Bettina.
Well, thank you, and we appreciate the challenges and the rewarding nature. So we appreciate all you do. We see that also on the sim side here because it's been really challenging and rewarding, but we see terrific momentum and opportunity, and especially how CMS has enabled all the pieces to come together, really connecting the marketplace, the Medicaid, expansion, SIM, and really to have that be a catalyst to move things forward. So given all the, how that all fits together rather elegantly under the ACA, maybe the only person to say that, and all the focus around the marketplace and all of that, how do you plan or foresee us kind of winning that communication strategy and that outreach, and that that is the toughest piece. We talk about being patient-centered and consumer-focused, and we have great things going on, but then how do we communicate that to the broader public and frankly through the media as well? A big challenge there.
Yeah. God, I wish I knew.
And we'll be happy to help in any way we can.
I honestly, we were actually joking about this a bit on the way, although not joking. So I'm a content person, and I'm so not a communications expert. And I actually had a meeting the other day where I was like, okay, I can't take this anymore. I will share with the content with you, and you tell me how you want to spin it. Because I was like, I can't. It's the right critical question. The short answer is I don't know. I feel like there's probably tenets of getting it in language people understand, consumer testing, and really understanding that language, hitting those key messages, having people in states and communities and organizations across this country also on message.
And that's what we're doing. We're doing focus groups, communication
Yeah.
strategy, what works, really testing that out to drive things forward, because that's the hardest piece. And everything else is hard, but that's really hard on that public front.
Yeah, no, I think you're right. And I think within CMS, for better or worse, a lot of our comms activity went to the marketplace work. And so, I mean, I literally started funding some communications people in our Office of Communications because I was like, I got to have somebody who's helping me think through this, who's got a background. So I think it's a critical issue. Love to think through it with you and others. And on the SIM work, just to say this, sorry, I know you.
No.
When I started, that team had like 6 people and was pretty underinvested in. We've built that team up a ton, and I think it's a critical model. I mean, I think it's really a model with a lot of potential.
Yeah, my comment was going to be that the engagement of the public, I have strong feelings about that. I think that most of what we do becomes very, very difficult unless the public is pushing us. And if they don't know, then how do they do that? So it's really important. We had one last, Vernon, yeah.
Dr. Conway, thanks. You piqued my interest earlier when you said that we need to build capacity, the tools and skills that people will need to build capacity. I was wondering if you could talk more broadly about what that portfolio looks like. We'll need.
Yeah, so let me name a few possibilities or a few parts of that portfolio. One is I actually put some of the state innovation model work. You could debate, it's kind of in all 3 buckets, but I think it's also an investment in capacity and sort of transformation at the state level. The Transforming Clinical Practice Initiative, the sort of working with clinicians and physicians, I think would be an example of a major investment in tools and capacity. Partnership for Patients, I would argue, is an investment we made in tools and capacity. The early results are very positive. Now you have the question of, do you extend for another year? The attribution is hard on this one, not to get, but do you extend for another year to try to solve the attribution issue? Underneath that, I actually think there's some innovation on capacity. I literally was talking to a tool one day last night at like 9 o'clock. I love him. And we got in this discussion around with the 10 most important problems we have, we should have a measure for do we have the tools to improve this care? And he always brings it back to checklist, but probably right. Do we have the right tools to change people with multiple chronic conditions? Do we truly know everything we need to know? So let's end of life care, which he's writing a book about right now. Do we really know what? And then we need to research those, understand those tools, and then implement them broadly. So he was making the point that I've made before, that things like Lyme infections where we did that is terrific, but we need to now do that for our top 10 biggest problems and then go from there, which I think is really on target. I'm not exactly sure how to do it. We'll need some help, but it was a good conversation.
Well, thank you, and it's
Thanks.
Inspiration to us, and and your job may be very hard, but it's very important. We applaud you for it. So thank you.
Thanks for having me.